Hello, everyone. Welcome to another Sips VMR. Today, we have a very special guest with us, and we're going to have a special session, which is a partnership between VMR and a Women in Medicine Summit. And because of that, we have Dr. Jain, which is the CEO for the Women in Medicine nonprofit, and also for the Women in Medicine Summit, and also an hematologist and oncologist at UIC. And we also have Dr. Hippo, which is a chief fellow at UIC. Dr. Jain, would you like to introduce yourself?
Absolutely. Thank you so much for the kind invitation. And I'm so excited to be speaking to you all this evening. So my name is Dr. Shikha Jain. I am an associate professor of medicine at the University of Illinois Cancer Center. I'm also the director of our GI oncology program and the director of communication strategies. And then I'm the founder of the nonprofit Women in Medicine. I'm also the founder of the Women in Medicine Summit. And I am a GI oncologist and really excited to be here today with my fabulous fellow, Dr. Neha Hipple.
Dr. Jain, something that we like to ask our guests is tell us something you like to do outside of medicine.
Oh my gosh, I love doing so many things. So I used to be a singer for years and years and years. I was a singer, and I sang on stage, and I actually recorded. I was a backup singer for Regina Belle when I was very young, and then I love running as well. So back in residency, I ran my first and possibly only half marathon. But I love running, and my goal is to start running again. And yes, you're totally right. And I'm a huge tennis fan, and I played varsity tennis through high school, beginning of college, and love playing and watching tennis.
Wonderful. Thank you for sharing with us. Dr. Hippo, would you like to introduce yourself?
Sure. Thanks for having me, everyone. This is kind of nice. I was able to collaborate with you all during my internal medicine in chief year, so this is nostalgic for me. But yeah, I'm Neha. I'm one of the third year chief fellows over at UIC. I am in the exciting process of finding a job, which is very exciting, at UIC. So I am mostly interested in solid tumor oncology. A big, pull for me to go to UIC in particular was a lot of the research and emphasis on cancer equity, which has become a passion project for myself. I'm also interested in cancer genetics too. But yeah, I'm happy to be here.
Awesome. And what is your favorite thing to do outside of medicine?
So I too am a big tennis fan. So I actually started taking lessons again and playing when I moved to Chicago for fellowship, just because it's very important to have hobbies outside of the hospital. And so it's been something that has become my whole personality now. When I was in clinic with Dr. Jain, I remember we used to watch the Open whenever we could in between patients. So, but yeah.
Wonderful. Thank you for sharing. And today, facilitating the session with me, we'll have Deborah. Would you like to say a few words, Deb?
Hi, thank you so much for being with us. We are really excited for the session. And yeah, I think we can start with the case.
Good. All right. I will go ahead and get started. Let me know whenever you want me to take a pause, but I'll just start with the HPI. So the chief complaint was hypercalcemia. And so the patient is a 63-year-old gentleman with medical history, which was known for type 2 diabetes, hypertension, and hyperlipidemia. And he was sent to the emergency room after he was seen by his primary care doctor when they did basic lab work and noted that he had a calcium of 14.1. When he was in the emergency room, he said he was feeling in what he thought was his normal state of health. He did note that he's been dealing with a cough on and off for the past couple of weeks, some maybe a little bit more dyspnea with exertion when he's moving around. That led to further questioning, and later discovered that he was also having a decreased appetite. And he also noted that he had about a 10-pound weight loss over the past 12 weeks, which was unintentional. And then on further review of systems, Everything was largely negative beyond from what I just said, except for the fact that he also noted to be constipated, noting that his last bowel movement was about a week ago. And I'll pause there.
So one thing I just want to point out is hypercalcemia, a malignancy. When you learn about it in med school, I feel like they try to point you, on your board tests, they try to point you towards very specific things. Neha, do you remember, like in first aid, when they think hypercalcemia of malignancy, what types of things do they point you to typically?
I mean, constipation was a pretty big thing. Moans, groans, abdominal pains, those are the classic.
Moans, groans, and stones is what I remember. Kidney stones is another big one. So the other interesting thing that I always find with hypercalcemia and malignancy, I don't remember a lot of hearing about hypercalcemia due to GI malignancies. And that's something that I think is really fascinating. We thought about it more with endocrine problems. We thought about it more with other types of malignancies, but it can be something that when you are presented with somebody with hypercalcemia, it's sometimes malignancy may not always be the first thing in your mind, but it's definitely something to think about when you're in the emergency room, or if you're that medical student on IM, sub-I, and you see somebody with a newly diagnosed hypercalcemia and weight loss, be thinking, along with your endocrine differential diagnosis, be thinking of malignancies.
I can continue with a little bit more of his history, if that's helpful. So for his other past medical history, like I mentioned, he has a history of type 2 diabetes, hypertension, as well as hyperlipidemia. For his medications, he is taking a statin. He was taking vitamin D, 1,000 units daily. He was on Jardiance, 10 daily for his diabetes, lisinopril 10 daily for his hypertension, and then metformin 1,000 milligrams BID. And then regarding family history, I'll say he wasn't the best historian, so he's noted no significant family history. When asking more specifically about cancer-related histories, no history that he was aware of. Socially, which was significant, he noted to be a tobacco user. So he's been smoking cigarettes for the past 40 years, smoking half a pack a day, each daily. Additionally, he also was noted to drink about a 6-pack of beer every day. He says this has just kind of been his routine for several years. When pressed a little further, no episodes of alcohol withdrawal or anything like that, but did note that, he had family with him and noted that this was an ongoing issue. Besides that, nothing pertinent with his social history. And then no known allergies as well. And then I can pause there if anyone has any comments or questions.
I saw somebody in the chat asked, did he have any abdominal pain? Was there any abdominal pain in any of his history, Neha?
So initially, no. When he was in the emergency room, he was saying he was constipated for about a week, which would make most of us think that you were probably feeling, having some sort of pain. But he did note some nausea when pressed a little bit further. But really, the only other thing he had mentioned outside of his PO, like decreased appetite, was this intermittent cough that he was having.
Another question that's being asked, was he taking any magnesium or any multivitamins?
Nothing of the sort, no. Just those meds that I had listed.
And I think that's a really good point. That's a really, really good point, especially we at UIC, we serve a very large Hispanic population, also a very large Chinese population. So oftentimes patients are taking external vitamins and herbs. So definitely something to ask. And I like the question, or a ton of Tums, because you can actually overdose on over-the-counter medications like Tums. So all really good questions, but no, he wasn't on any of those types of things.
I can go to the physical exam, or do you want to pause?
We can ask about if the social history what influence and make a difference in this patient.
Do you want to start and then I'll add more?
I think certainly, especially like Dr. Jain was alluding to, our social history is sometimes just as important as our regular medical history. In this patient in particular, and in general medicine, someone who is drinking a 6-pack of beer a day, for however many years, I'm sure, you're certain to have some sort of even malnutrition. So expecting some sort of electrolyte derangement wouldn't be unheard of. And then when we think about certain cancers that are more prone to certain risk factors, we of course think about lung cancers when it comes to, a big smoking history. But additionally, when we have someone who's drinking a lot of alcohol, then the ones that kind of leap out to us are, of course, HCC. And that's kind of where my mind goes.
Absolutely. And I think also along with the social history of smoking. So one, we always talk about, you need to know how long they've been smoking, how many packs per day, the basic things that you need to get. And then also we're seeing an uptick in recreational marijuana use and marijuana smoking, which there hasn't been a lot of data that's come out to talk about where marijuana and smoking marijuana in particular might impact malignancies. So other external things that patients might be taking along with alcohol and cigarettes is important. Cigars is another thing that we sometimes forget to ask about. I have some patients who swear they don't smoke, but they end up saying that they do smoke cigars and they don't consider those to be cigarettes. So just important to delve into that history a little bit. Also, one thing we did not talk about in the HPI, but when we talk about weight loss, so there's a difference between a weight loss of 5 pounds over 5 weeks versus 5 pounds over 5 days, or 15 pounds over a couple of weeks as opposed to a couple of pounds. So when you're talking about weight loss, make sure you get an idea of how much and over what period of time. The other thing that we didn't have to think about like 2-3 years ago, but we're seeing more and more patients who are taking drugs like Ozempic and Mounjaro. So if somebody mentions that they've had a rapid weight loss, make sure they're not on any sort of weight loss medications, or they're not intentionally trying to lose weight. So something just to keep in mind when you're going through the HPI. Those are things that I probably would not have thought of when I was in training, but something that's now become a part of our everyday dialogue.
Yeah, I mean, I've had a patient who I was on surveillance, watching for surveillance from a history of cancer, and he, because of his diabetes, was on Jardiance and ended up losing 40 pounds pretty rapidly, which, triggered me a bit, but everything was okay. So certainly a good point.
And then the other thing, we talked a little bit about family history, but we can talk a little bit about that as well here. When you talk about family history, when somebody comes in with something like hypercalcemia, there's already been in the chat some really good thoughts about things that need to be done for treatment. But when you're thinking about family history, the MEN syndromes, so syndromes where you're thinking about parathyroid problems or pituitary problems. So not just asking the basics, hypertension, diabetes, and cancer diagnoses. You also need to be asking, do you have any history of abnormal, thyroid dysfunction and things like that? Because that in a family history can be very telling when you're doing your workup for what's causing the hypercalcemia and what the patient may be at risk for. So one question that's being asked, and I don't know, Dr. Hipple, if you know the answer to this, but what was the finding on HPI that led to taking a calcium level?
So the patient was actually being seen by the primary physician, who I think just got a repeat CMP. Calcium just ended up being thrown on there. And then when it resulted, they sent the patient to the emergency room.
I always tell my trainees, don't ever order a test where if it's not abnormal, you don't know what to do about it. So if you're going to order a test, know what you're going to do if you order it. So we're glad they ordered the calcium, because without it, we might not have gone down this path. Great. All right. Should we keep going?
All right. So I'll go to the physical exam. So vitals wise, blood pressure was 174/72. His heart rate was 68. Respirations were 17, and he was satting 98% on room air. Generally, he appeared well, well developed. He did not appear ill or cachectic looking at all. He had, for his HE&T exam, was normocephalic, atraumatic, no scleral injection noted bilaterally. His extraocular movements were all intact. no thyromegaly, no JVD on exam, no murmurs, regular rate and rhythm. He was moving his air well. He was in no respiratory distress. His abdomen, you could say that he was maybe slightly distended, but no tenderness with palpation. No hepatosplenomegaly that anyone was able to appreciate. And then for his neuro exam there, he was alert and oriented. He was moving all of his extremities well. He had no dysarthria. He did have poor memory recall, but that was really the only significant thing there. And then from his extremities, they were warm, they were dry, good pulses throughout, and then no skin rashes were appreciated either.
So things to point out from the physical exam. So again, I want to focus on weight loss for a minute, because when we think somebody's lost, how many pounds did we say he lost? 14 pounds, 15 pounds?
Yep.
So, it was noted that he was not cachectic looking. So remember, when you're looking at somebody and they say, I've lost X amount of pounds, just because they don't look like they're very skinny does not mean that they have not actually lost that weight. So that's something, just physically looking at someone, you can't always tell if they've had a significant amount of weight loss. So just something to be aware of. The other thing is on neuro exam, the fact that he had some poor memory recall. So obviously, hypercalcemia can cause confusion. It can cause altered mental status, but you also want to be thinking about other things that could be causing altered mental status or confusion. Does he have any indication that he might have had a stroke? Is there anything that looks like he might be having a TIA? And so this is where having other people in the room, if he's got family or friends, sometimes getting that extra history from other people can be very useful, especially if the patient's having any memory issues, short-term or long-term, or isn't able to give a great history. Our patient population, especially, we have a lot of patients with lower health literacy as well. So sometimes having family or friends in there to help supplement the information is important. I also want to make sure we don't let our implicit bias impact our assessment of patients, because sometimes I've seen patients who have lower health literacy who are documented as not compliant, or documented as having poor memory or poor understanding, when in actuality, it's just that they don't have the health literacy to follow along with what the physician or nurse speaking to them is talking about. So if you get to the point where you think somebody's having memory issues, I would say delve into that a little bit deeper. Make sure that it's not a health literacy issue, or it's not, make sure it's not a confusion versus an altered mental status versus short-term memory. So really dive in a little bit more to understand what is the neurologic complaint that you are assessing them for.
Dr. Jain, we see that the majority of the findings that we have in the physical exam are characteristic of hypercalcemia. But I would like to ask you, in a patient that you are concerned for malignancy and you have hypercalcemia, what else would you look for in the physical exam that could give you a clue of the type of malignancy we are dealing with?
So it will depend on the type of malignancy you're thinking about. So the challenge becomes, there's a lot of malignancies that can cause hypercalcemia, right? So if you're dealing with a female patient, you need to think, have they had a recent mammogram? You can ask them, have you noticed any breast lumps or any changes in your breast? So that would be something to be thinking about if you're thinking that breast cancer may be on your differential diagnosis. If you're thinking about something like a pancreatic cancer or hepatocellular cancer, those things you can look for ascites. You can look for asterixes, where you have the patient put their hands out in front of them, see if they have any of those flaps that you typically see in people who might have some liver failure. Palpating the liver to see if you've got any hepatomegaly. Sometimes in somebody who has a hepatocellular carcinoma, you can see a pronounced or a more palpable liver. Lower extremity edema can sometimes be indicative of some pressure on the lymph nodes in the groin area. Again, non-specific finding, but something that you can look for. Those are some of the main things I would say on physical exam. You can also look for signs of liver failure. For example, I mentioned the asterixes, I mentioned hepatomegaly. You can look for ascites on palpation or a fluid wave. Those are kind of some of the main ones for GI malignancies. If you're thinking that the patient might have a lung cancer, that can cause hypercalcemia as well. For those patients, a really good lung exam is very important, listening for wheezes, listening for rhonchi, anything that might be indicative of a pulmonary source, and also getting a really good understanding, especially with his smoking history, is there any change in his respiratory status? Has he noticed that he is having more dyspnea on exertion, more shortness of breath? Sometimes in patients, if you worry if they've got a mass or something that might be causing SVC syndrome or compressing anything in the mediastinal area, ask them when they lay down if they notice any change in their breathing or if they hear a pulsating sound in their ears. Sometimes that can be indicative of SVC syndrome. The other thing would be when they raise their arm, looking for signs of swelling, so SVC syndrome or a bounding pulse. So those are some other things that you can look for.
Awesome, thank you. Should we go ahead, Dr. Hippo?
Yeah, absolutely. So I'll start with some of the basic labs that were done right away. So for the patient's CBC, the white blood cell count was 9.9. Hemoglobin was 16.6, and platelets were 195. I'd be a bad hematologist if I didn't mention that the differential was normal. For the chemistry, the sodium was 128. The potassium was 4.5. The chloride was 89. CO2 was 27. The BUN was 16. The creatinine was 1.4. And then the glucose was 199. Going into the patient's liver panel, the AST was 65, the ALT was 53, the ALK phos was 356, the total bili was 0.9, and then the direct bili was 0.3, and then the albumin was 4.2. I do have a GFR for you. It was 99. And we also had a lactate that the ED did, and that was 3.8.
Do you have handy the if he had macrocytosis or microcytosis or of his red blood cells by any chance?
I do. I don't, unfortunately.
I can see if I can pull it up while you're looking, because that was a question in the chat.
And those were the first set of labs that that was obtained. And I will mention, looking back at the previous kidney function, that this looked to be about the patient's baseline, maybe slightly higher baseline, closer to 1.2-ish.
And I don't know if I've got that differential with the macro or microcytosis handy either.
I can look at it.
Okay.
Dr. Jain, I'm curious how you make progress with these labs that you already have, and what are the exams that you would expect to have next?
Well, so obviously the calcium is the biggest concern. And then as was pointed out in the chat, the patient is also hyponatremic, and hyponatremia can also cause altered mental status and confusion. So we now have two different things that could be causing the patient to have altered mental status. The hemoglobin of 16.6, that's obviously elevated. So the question is that concentrated, or is there also a hematologic disorder underlying all of this issue? Because at this point, remember, we don't have a diagnosis. Glucose of 199, he does have a known history of diabetes, so that's not overly concerning. And then so those are kind of the biggest things that jump out to me on the initial laboratory values that are of concern. The good things are we're not seeing very high white count, so it doesn't look like the patient is septic, because I have seen people have wildly abnormal electrolyte dysfunction when they are septic. So at least right now, infection does not seem to be in the differential diagnosis. And albumin of 4.2 would be more indicative of this isn't whatever it is. It's not something that's been going on for a very, very, very long time. When we talk about the fact that the patient has lost, 14 pounds, but the albumin is still within normal limits, that makes me feel a little bit better that they are not severely malnourished at this point. Anything else that you can think of, Dr. Hipple, that I missed in the laboratory? Well, and I guess one other thing, the BP is 174 over 72, which is elevated. And so obviously that is of concern. Then that's in the physical exam, obviously, but also something to pay attention to.
Yeah, I think you covered a lot of it. The other thing to consider, just trying to think about the patient's history, like you said, we don't have a diagnosis. Typically, a hemoglobin that's 16.6 would kind of make everybody think a little bit. Of course, we want to think about, is the patient contracted? Sounds like they have a lot of alcohol use, so remembering common things being common. Does the patient just need to be fluid resuscitated? The lactate was 3.8, so slightly elevated. The other thing to consider also is, this is a little bit outside of the scope, but just to put it out there, there's such a thing as secondary erythrocytosis. So knowing that the patient does have a history of smoking, common things are also common that we do see a lot of patients that do have a slightly elevated hemoglobin like this in the setting of a long-standing history of smoking. And then the last thing I'll comment on is typically when we see patients and you were looking at their LFTs, I'm always wondering, is something obstructing, like we've alluded to. So the fact that the belly looks okay, the patient didn't look overly jaundiced or anything like that, points away just off the bat of something that's causing a big obstruction.
And I like one thing I want to point out that's being discussed in the chat, which I think is really important and good to remember. Dr. Hipple mentioned the smoking history. You can also have some baseline abnormalities from your hemoglobin and from just the fact that you might have sleep apnea. You might have an issue from chronic obstructive pulmonary disease, COPD or emphysema. Somebody mentioned that the widened pulse pressure could be secondary to a hyperdynamic state. So also something to think about. So again, kind of looking at the big picture, the smoking history can contribute to a lot of things. Another thing that would be helpful would be, has he ever gotten pulmonary function tests, which I do not believe this patient had ever had pulmonary function tests. So we don't know if he's got a diagnosed underlying emphysema or COPD that could be contributing as well with his smoking history.
And Dr. Jain, what you will order next for this patient?
Well, so one of the questions that was asked in the chat, which I think is really important, is do you start treating the hypercalcemia as you are kind of doing the workup? And so, I joke, I think a lot of oncologists joke that in oncology, the tissue is the issue, and we don't start treating things until we know if we have a tissue diagnosis. However, oftentimes we get to the point where a patient has an acute issue that needs to be acutely reversed while we are starting to do our workup. So I think that to answer that person's question in this particular case, we will talk next, Dr. Hipple and I will talk next about what the workup will be that we did embark upon, or we should embark upon. But I think the most important thing to remember is we have to deal with the acute situation. So I think to answer the question, starting the treatment of the hypercalcemia to start reversing that while we're also ordering workup. So things that I think would be beneficial at this time, if you've got a hypercalcemia, you've got weight loss, you've got a smoking history, starting with a CAT scan of the chest is absolutely probably one of my first steps while we're working on treating the hypercalcemia. I oftentimes, because I'm an oncologist, I will often order a CAT scan of the chest, abdomen, and pelvis to cover the whole body at one time and to prevent the patient from having to go back, especially because we also know that smoking puts you at risk for things like colon cancer, hepatocellular carcinoma, renal cell carcinoma. So I think at this point, with all the information we have, I would order a CT chest, abdomen, and pelvis while starting to think about how are we going to start treating this hypercalcemia. And I also want to say in med school and residency, we used to joke that there should just be a CT scanner like as the door to the ER, and everybody who rolled into the ER should just get a CT scan as they roll in, because so many people get them. I don't think that is a good idea for posterity, but that's a joke we used to make because so many of these patients end up getting a full body scan. But in this case, it's needed.
So like Dr. Jain said, the ED also first things first, they did start treating the hypercalcemia. So I will mention fluids were started while the patient was in the ED, started at a higher rate, 200 cc's per hour, and they were getting normal saline, I believe. And so that was starting while the imaging was starting. So the patient first got a CT of the chest. They also, in the ED notes had talked about the fact that the patient had complained of a cough with a smoking history. So that's kind of what went, through their head. And so the CT chest showed that there was no pulmonary embolism. They ended up doing a CT-APE actually. And then the lungs beyond that were clear, but what it did show was that there was multiple hypodense enhancing lesions throughout the left hepatic lobe that was consistent with a malignancy because the CT chest caught the liver. And then from the CT chest, they were also able to see that there was some abdominal lymphadenopathy, which could be related to a malignancy.
See, needed the whole body.
So with that, once they saw that, they went ahead and got the CT abdomen part as well. And so the CT showed, again, extensive hepatic malignancy, some mild splenomegaly, intraperitoneal fluid, and some possible gastric edema. There was multifocal, they were saying it could be multifocal or multicentric hepatocellular carcinoma should be considered, but also noted that the differential also includes hepatic metastatic disease. And then there was also periportal and celiac adenopathy, mild splenomegaly. Like I had mentioned from the CT chest, there was also intraperitoneal fluid within the pelvis, possibly some loculated against the ventral margin of the liver, and then some mild gastric edema, which was suspicious for enteritis.
So I want to bring up something that's in the chat that we haven't even touched on yet, is that hypercalcemia can also be very common in patients who have blood malignancies. So diffuse large B-cell lymphoma, definitely high up on the differential, and other leukemias and lymphomas can absolutely present with hypercalcemia. So in this case right now, Dr. Hipple, what are you thinking? Are you thinking diffuse large B-cell? Are you thinking a lymphoma? Or are you thinking more of a solid tumor type diagnosis?
For me, looking at this, I'm probably thinking more solid tumor, but what I've learned in fellowship is the easy blood test to go to when I am concerned about a lymphoma or some other heme malignancy is always to get an LDH. And so that's just something to keep in mind.
Absolutely. And I agree. I mean, the radiologists were kind enough to report here what they think that this might be. They're highlighting multifocal, potentially hepatocellular carcinoma versus a metastatic disease. We're also not seeing a lot of lymphadenopathy that you'd be more likely to see with a lymphoma that was causing hypercalcemia. They are commenting on periportal and celiac lymphadenopathy, but again, not your typical lymphoma presentation. I've also found, and again, I am a hematologist and oncologist, but I haven't treated lymphoma in a little while, but I feel like lymphoma patients often present also with more significant weight loss. They also have symptoms often like night sweats and things like that, which this patient did not necessarily present with. So again, that's not an absolute, but something to be thinking about. But lymphoma definitely on the diagnosis, on the differential diagnosis spectrum when you're thinking about hypercalcemia.
And I don't have the exact LDH in front of me, unfortunately, but it was normal, which made me feel better. And again, an LDH is also a little bit of a red herring because it's also an inflammatory marker. So there are certain times when you do expect to see an LDH elevated, especially in someone who you're concerned for a malignancy. So it's never black and white.
Absolutely.
And so if we are ready, I can, all of this imaging made us get a couple of other lab work. So first things first is we talk about tumor markers. So I kind of already alluded to one, which was the LDH. But the other tumor markers that were obtained was a CA19-9. And this was 1,691. An AFP, which was 31.7. And then the CEA, which was 3.
And so I want to make a point on these 3 particular tumor markers. So AFP, we often get to look for hepatocellular carcinoma. CA19-9, we see elevated in pancreatic and other pancreatic biliary carcinomas. The CEA, we see commonly with colon and rectal cancer, but you can also see a CEA elevated in other GI malignancies. One of the nice things about GI malignancies is many of the tumor markers cross over. So sometimes you'll have more than one tumor marker that you can follow, but those are the typical ones that we often see elevated in specific malignancies. And we're also getting asked if there was a PTHRP ordered.
All of that was ordered, but in real time, it does take a bit of time to get that back. So we actually didn't have that available to us at this time, but excellent question. And so at this point, we're concerned for something abdominal going on. And so this was a conversation where we discussed oncology is a very much a multidisciplinary field. So at this point, we also got our surgeons involved, because if we're going to get tissue, we also most often discuss the idea of, is this something that's resectable? And so we did talk with our liver colleagues and our surgeon colleagues about what should we do next? Is there different types of imaging that we should be getting? Typically, when we're trying to look at a liver malignancy, a CT abdomen's great, but also typically we'd like to look at MRCPs or, even a CT phase, like liver study, dedicated study. So that's actually what ended up happening. The patient got a dedicated CT phase liver with contrast. It didn't really tell us anything that we didn't already know. It did mention that in the lungs, there, like we said, was no acute abnormalities, but there was a 0.5 centimeter lung nodule at the right middle lobe. Unclear how long that's been there or what that's about. The adrenal glands looked okay. The spleen looked okay. The liver, like we had obviously talked about, shows that there's this heterogeneous enhancing mass within the liver, predominantly in the medial left hepatic segment, which is best seen on the portal venous and delayed phase. And then they were measuring this to be in greatest dimension, 10.8 centimeters by 9.1 centimeters, so pretty significant. And then it also mentions that there are some adjacent scattered lesions to that mass itself as well.
So one thing that I think is important to remember, so if we're thinking about hepatocellular carcinomas are often diagnosed on imaging because they are very vascular, and sometimes getting a biopsy on them can be risky, higher risk. However, in this particular imaging, I think it's interesting to note that they're still, again, saying this is not a typical hepatocellular carcinoma looking mass. It could be metastatic disease. And so in those situations, we often will push for a biopsy because unless it looks like your typical HCC or hepatocellular carcinoma, we want to know what we're dealing with. So as I said earlier, the tissue is the issue. And that is when we start really thinking, do we need to get a biopsy or do we treat it as a presumed HCC?
Yeah, so in this case, the surgeons looked and they didn't think this patient has anything resectable at this time. And so we discussed about getting a liver biopsy. And so we did get the pathology. And the pathology, goes into, obviously with hematology, we're doing different stains of the tumor cells to try and help us figure out what the histology of the tumor is. And then if we can, the origin of where the tumor came from. So it was positive for a bunch of different stains, which I will spare all of you those details. But all in all, it showed that it was dealing with an adenocarcinoma. it is suggestive of something pancreatobiliary, like Dr. Jain had alluded to. However, we weren't able to rule out something gastric or GU primary. Those things could not be excluded. So we're in a place where we know we have an adenocarcinoma, but the origin of it can't be pinpointed exactly.
And this happens often when I talk to patients about where their cancer tumor of origin is. I tell patients we think about 3 different real components when we talk about cancer. One, we think about, do we know where the site of origin is? Like, is this a lung cancer? Is this a colon cancer? Is this a liver cancer? Sometimes we don't get that information. Sometimes we don't know where the site of origin is. The second thing we look at is a type of cells. So for example, in this case, we're talking about adenocarcinoma as opposed to a squamous cell or a small cell. And then the third thing we talk about is the stage. Are you stage 1, 2, 3, or 4? And in this case, we can tell the patient you have an adenocarcinoma of an unknown origin that's metastatic because there's more than one lesion.
Dr. Jain, I'm curious to know, at this point that you can identify the primary lesion, what would be the next step? Would we start treat this patient, or would you order more exams to try to identify the primary lesion?
So the first thing you do when you get to this point is you want to assess the patient's performance status. So when we talk about performance status, it's how active the patient is. And the score goes from, if you're looking at an ECOG performance status, from a 0 to 4, 0 being the best, 4 being the worst. And so the first thing you do is you assess, will this patient even be able to tolerate treatment? Because if they are a performance status of 0, 1, or 2, then you can present treatment as an option to them. If they're performance status 3 or 4, then you need to really think, is treatment going to actually cause more harm than good? So that's the first thing you need to assess. Then the second thing we talk about is, in a patient like this, is we talk to them about what we're dealing with, which is a likely poorly differentiated aggressive adenocarcinoma. We know that it's poorly differentiated because we can't tell the site of origin, and we can tell that it is aggressive because 1, it's poorly differentiated, and 2, because it has already become metastatic. So we explained to the patient that unfortunately this is not a curable cancer, this is not a curable disease, but it is treatable. So further testing we would do at this point, we would send off next generation sequencing. So Dr. Hippel, do you want to explain a little bit about what next generation sequencing is, and then I can explain a bit more?
Yeah, so next generation sequencing, I mean, this is really just changing the way that we treat oncology patients now. We're now able to test and sequence patients' tumors. And that helps us decide whether or not there's anything actionable. Are there any actionable mutations that we are seeing present on the patient's tumor? Certain things that we can, test for that, we do it in the GU cancer space, often in the GI malignancy space often, as well as the lung adenocarcinoma space. And this is something that is really helpful. We can also test for other markers, which is pertinent in the GI oncology space in particular, such as PD-L1. It also looks for MMR, HER2. These are all, a little bit more in the weeds of oncology, but this is all about kind of how we can target our treatment further. And so in this case in particular, we did send the patient's tumor for next generation sequencing. It's actually still pending. I looked it up earlier today to see if we had anything left. But again, it's looking for all these different types of mutations that would be specific to this patient's tumor to see if we can target anything in particular.
And that's a really good point. So next generation sequencing, we send it for, as Dr. Hippel mentioned, we send it to, number 1, get more information on, are there targets that we can actually give drugs that will specifically target. You can also do tumor of origin, where you can get a better understanding of where the tumor may be coming from. But again, as she mentioned, it's been several weeks since this was sent out and it's still not back. So we don't delay starting treatment based on the next generation sequencing. We often will start treatment with the information we have. And then if we find out the patient has an actionable mutation or an actionable target, or is amenable to something like immunotherapy, which is different from chemotherapy, then we might consider starting that as the next line of therapy. So the patient would stay on whatever treatment plan we started them on, for as long as it continued to work. And then we have that next generation sequencing to help guide us in the next line of therapy when the patient eventually stops responding to the first line of systemic therapy that we've started.
So thank you for explaining all of that. Dr. Hippo, just for the sake of time, would you like to move on with the final diagnosis?
Yeah, so this is one of those cases in oncology where we don't typically have a quote unquote final diagnosis, but I can let you know what we ended up doing. So with a cancer of unknown primary, typically, we have to kind of look at the clues that we're given. We have in the cancer world, there's something called the NCCN guidelines. And so this is something that's our rule book, and that helps us guide a lot of our decision making. But it can help us figure out and pinpoint exactly what's going on. So, this doesn't necessarily relate to this case in particular, but if you are having a female with this issue, you want to consider gyn-onc type of malignancies and get a CA 125. We did get a PSA to make sure that there wasn't any concern for a prostate cancer. If this was a younger male who was less than 65, you would want to think of testicular cancers and get beta HCG or an AFP, testicular ultrasound. So there are different ways to try to at least narrow down and exclude certain malignancies if you can't necessarily get a diagnosis on the pathology. Given all of the clues that were given in front of us, especially with the CA 19-9, what we're dealing with here is largely a GI oncology malignancy. So with that, we have to discuss, types of systemic therapy. And so at this point, the patient is being treated for a GI oncology, likely something pancreatic in origin. And he is getting a combination of treatments with something called capecitabine and oxaliplatin.
And one really important point, so this is a cancer of unknown primary, but as Dr. Hippel mentioned, many of the clues are pointing us to a GI origin. One of the nice things about GI oncology is there's a lot of drugs that actually the same backbone will apply to pancreatic cancer, gallbladder cancer, colon cancer. You can actually use similar drugs. And so the chemotherapy agents that are being used in this particular patient have been found to be effective in pancreatic cancers and biliary cancers and even colon and rectal cancers. So that's why that regimen was chosen, because it has some crossover. Now, the hope is once we get this next generation sequencing back that you get more information where you are able to actually target specific agents or specific markers on the tumor. If there is any evidence that immunotherapy may be a benefit, that would be a great option for this patient. But again, you have to wait for the next generation sequencing to come back to see if there's targetable lesions or if immunotherapy is an option.
Amazing. Thank you so much for this case. And Dr. Hippo, maybe we can start with you if you want to share some teaching points that you learned with the case.
Yeah, I think especially to this audience, something that's so important about this case is that multiple things can be happening at once. I think, when we see the sodium, when we see the calcium, when we see liver mets, all of these things, it's not always going to tie up into one perfect diagnosis. I think the patient's alcohol use was a big contributor to potentially the patient's sodium. As he got fluids, his sodium improved, his kidney function improved, his calcium improved. I'm certain that his malignancy was also contributing to his calcium, but I do think it was more than one thing happening at once, which is always just so important for any patient that you're dealing with.
Thank you so much. And Dr. Jain, do you want to share some teaching points from this case?
Absolutely. I think two really big teaching points. One is if you have acute issues, don't delay treating the acute issues while you're working up the problem. You don't want to delay treating somebody for hypercalcemia while you're trying to figure out what's causing the hypercalcemia, because you could end up with major complications. The other thing that I think is really important, and it's hard for all of us, is don't get tunnel vision. Think broadly about these diagnoses. Hypercalcemia can be indicative of so many things. We only covered a few few of those things. And I'm obviously an oncologist, so I will constantly be thinking that it's cancer that's causing the underlying issue. But make sure that when you're approaching these patients, you're thinking with a very wide lens. You want to rule things out, and you want to be very methodical in how you think about these patients and how you do the workup.
Wonderful. Thank you very much. And uh, so even though it was a very specific case that we talked about, oncology was a very good opportunity to do an overview of a lot of things in on internal medicine. So thank you very much, Dr. Hippo, for bringing up this case. Um, and now transitioning to our other subject that we're going to talk today, specifically cheering women in medicine. I would like to ask you, Dr. Jain, what were your inspirations when you decided to create the Women in Medicine nonprofit and also the Women in Medicine Summit?
Absolutely. Thank you so much. So I started the Women in Medicine Summit about 7 years ago when I realized there were a lot of challenges and barriers faced by women in medicine when it came to career advancement, when it came to leadership opportunities, when it came to training or just education on a variety of topics that we don't learn about in medical school. And so I wanted to create a conference that provided that, not only that education, but also the opportunity for women and men from around the country to engage, network, and help find opportunities for each other, and really elevate leaders from across the country. And so that started, and then 9 months later, we had the COVID pandemic, and I had a lot of people reaching out saying, your summit was amazing, what else can we do? And so thus launched the Women in Medicine nonprofit. And now the nonprofit houses leadership programming. We have a speakers bureau, we have a research lab, and all of the initiatives that we're focusing on are really focused on not just providing opportunities for people to speak, providing opportunities for people to collaborate, but also creating networks across the country and across the world. Because one thing I've learned in my career, networks are what help you get to the next level. And I don't think I realized how important that was until recently. Our most recent initiative, actually, I'm going to drop it into the chat. Our most recent initiative, we just launched a Women in Medicine online community that we are allowing all women in healthcare from around the world to join. It's meant to be a safe space to coordinate advocacy efforts, to coordinate research collaborations, to just meet like-minded women from around the world. So any women who are on this call, anybody who identifies as a woman, we would love to have you join our community. Our summit happens every fall in Chicago because that's where I live, and I have 3 little kids, so it's easier for me if it's here. But we also plan events around the country, and we're looking for women ambassadors who are interested in elevating others and hopefully elevating themselves as well. So our 2 kind of mottos are Lift as You Rise and WIM Stronger Together, because we really believe that we can move mountains and close the gender gap in healthcare together, not only because it's the right thing to do, but also because it directly impacts the health of our patients, as we've seen in countless studies. So if anyone wants to donate to our nonprofit, I can also drop that link in the chat. We are always looking for donations and people who are interested in getting involved in whatever capacity, and would love to have all the women on this call and who listen join our online community as well.
Wonderful. Thank you very much. And I have to say that I volunteered in the last Women in Medicine Summit, and it was an awesome experience. I got to meet a lot of different people, do network, and seek mentorship. Was a unique experience, and I truly recommend any one of you listening that are a medical student and are interested in women in medicine in general. I think it's a great opportunity to do networking for sure. And Dr. Hippo, I heard that you are avid a participant in the Women in Medicine Summit. I would love to know about your perspective of attending the Women in Medicine Summit for so many years.
Yeah, I mean, thanks to Dr. Jain, she's a good example of practice what you preach. Starting in a fellowship in a new field, in a new city, it can all be very overwhelming. And so it's just as simple as finding people within your network who you can go to for advice and who you can talk to, not just about medicine, but life outside of medicine. And so after getting to work with Dr. Jain as a first-year fellow, I've been able to participate in some of the events. I've been lucky to meet other people who are around the same time of training as I am. So we can kind of discuss our, different experiences. I think to kind of make it through medicine, you need people on your side. And I think having these types of events, these types of networking opportunities, it really only helps you. So I've gotten to meet tons of other, female physicians who are here in the Chicago area, all over the country. I've actually even gotten to reconnect with people who I trained with even before I even started fellowship. And so I can't really say, enough great things about the opportunity.
And it's a lot of fun. Our events are super fun.
Time.
If you ever get the chance to come to an event, we love having fun. I just put on events that I want to go to, and that's how we end up having these fun events. So, and we love our medical students. We also lift up a lot of medical students and trainees. So would love to have anyone and everyone involved in whatever capacity you might be interested. Feel free to reach out to me anytime.
Thank you. Thank you very much, Dr. Jain, Dr. Hippo, for accepting our invitation to do this session in partnership with CP Solvers. We truly appreciate your time, and thank you for the amazing discussion. And thank you, Deb, for facilitating the session with me. Thank you, Yas, for collaborating with Teaching Points, and thank you all for joining us. It was an amazing time together. And stay tuned in for the next session in 5 minutes. Bye. See you.